Hello, dear friends. Let's look at a very interesting case today. It's not very big, but it's very illustrative because this case will allow us to more clearly understand what canine guidance is. Because canine guidance is very often used by doctors when constructing an occlusal scheme in patients with fixed constructions. I often ask such a question at courses. Look, an old man has come, for example, but he has absolutely no teeth. And I say, what kind of occlusal scheme will you make? And they say to me, well, since it is a removable prosthetics, we'll do a group function or balance type of guidance. That is, with lateral movements, either all the teeth will lead on the one side, or if the system is balanced, both teeth lead on the working side and on the non-working one. Good, I said, and then let us suppose that this patient has all his teeth implanted. Either he has one canine or his front teeth and canine and a removable denture. And they say to me, no, if this is no longer removable prosthetics, then we do a canine guidance. You know, this question itself baffles me. Why? Because what has changed with the patient? Due to the fact that he has a removable denture, does he himself become a different person? Has something changed in his head? No, just what do we want? We want the patient's head to fit our dentures. We do not want to look at our dentures so that they adapt to the patient's head. You still need to look at this individual characteristic of adjusting the data of his articular parameters to see what kind of occlusal scheme suits him. Therefore, the issue of canine guidance is rather complicated and debatable. Why do we choose it? We choose it for several reasons. The first one, it was found that when using canine guidance, it turns out that part of the muscles is relaxed, but not all. Second moment, the canine is responsible for almost all movements, not only for lateral protrusion, but also for protrusion movements, and it has a fairly powerful pronounced crown part, a root part that can withstand heavy loads and can control well the movements of the lower jaw. However, if we take a look at the canine itself, let me show it by fingers, then we can see the following, that during moving, antagonists move along the slope of the canine. However, if we tilt the slope, make it steeper, it will still be a canine guidance, but will it be physiological for this patient? We can flat it and it will be also a canine guidance, but which one to choose? Do you see that there are several options? So let's look at an example. The patient referred to us. This is a fairly old case. You see that he had a fracture of his canine. Please note that in distal section the teeth are in the crossbite, and after lateral movements over some time problems has appeared due to the overloaded canine. What did I try to do? The first one, we did not remove anything. I simply grind an overlaid pronounced tilt of the canine of the palatal surface. After some time the tooth has been strengthened, become denser, but after 2-3 weeks the patient came again, the tooth has broken. Therefore, it had to be extracted. Also pay attention to how far the lower canine is extended into the oral cavity. The fact is that these tells are the following, that not only the distal teeth, premolars and molars were in the crossbite, but in the crossbite there was a canine too. Therefore, in this case, we cannot do prosthetics only on canine. We must include its lower antagonist in this work. So, what do we do? You see, here is excessive canine eruption. We had to extract this tooth. For some time, the patient walked with a temporary plate. Immediate load has failed. And on this slide, I would like to show you that a second tooth took over some of canine functions. The fact is that there are still a number of points that we must take into account. Implant canines are a serious challenge for a doctor. Why? The fact is that implants do not have a proprioception. Proprioceptivity is a very important component that allows us to dose movements and occlusal loading. The second very important point, unlike teeth, implants do not immerse in the periodontal ligament, so we must also take this into account when moving, both under static load and when moving in dynamic load. because the immersion of teeth in the periodontal ligament is about 12 to 24 microns, while the implant respectively has 0, but with lateral excursion the tooth deflection will be up to 100 microns. Also, proprioception, once again it is absent on implants, plays a leading role in the formation of a certain pattern of movement and effort which is created during lateral movement. It is clear that if there is no sensitivity, then these tools will be overloaded with a high load. So pay attention, we start to our implantation. You see which bend angle forms the abutment of in combination with the crown. It will withstand sufficiently serious loads. This, of course, is not actual loads because, of course, we're interested in reducing the load of our implant. Installation, taking an impression. Now I will not focus on this. First, a temporary prosthetics was performed. Almost the last 15-17 years works with all the teeth on the implants. I start with temporary prosthetics, even if it's a single small work. For several reasons. One of them is preparation. We can see how the occlusal scheme that we have chosen is suitable for the patient, what happens to the tooth, whether there are pains, whether there are rejections, chips, and so on. That is, we still have such a test moment. The second, very important, we form a teasing zone so that the tooth looks completely natural. So the lower tooth was grinded and a classic veneer was made on it. We place the abutment on our implant. In this case, you see that I use a zirconia abutment, but in such situations, when we understand that the load is quite high, I use only titanium individual abutments for today. After all, there is a risk of zirconium split under such loads, and we don't want to risk since we plan that this work will serve not for 10 or even 20 years, but for a very long time. Therefore, here our task is to reload. But here, in this case, we still used a zirconium abutment, and a crown was made. Again, pay attention, I check in the oral cavity. The fact is that the work was carried out using an articulator. We set definitely that angle of inclination that is needed for the patient, but in this case, pay attention, I still carry out grinding. Why? Everything is quite simple. I want to achieve guidance on the second tooth. It's important for me to connect one more tooth in this case, which will also participate in lateral excursions in conjunction with a canine on the implant. What do? We connect a tooth with proprioception, which allows the patient to feel the load more adequately at first, without causing an overload of these teeth, and we also protect our implant from overload during non-axial load, since part of this overload goes to the second tooth, the lateral incisor. The final work for 5-6 years it's been in the oral cavity. The patient has no problems, thank God, despite the fact that, once again, all other teeth on this side are in the crossbite. That is, they can't help our canine in its work. So, thank you very much for your attention. If you had any questions about this case or how we did it, please write down it. Like, ask questions, comment, we'll be happy to answer to all of you. Or, if this question is wide enough, we'll try to create the same short video that will allow us to more clearly and dynamically talk about it. Thanks for your attention.